Hey there, I'm Professor McBride, labor nurse, OB instructor, and your guide to everything OB. Let's get to it. At birth, the lungs become the means of gas exchange for the newborn. Before birth, we were getting oxygen from the placenta. When the baby is born and we clamp and cut the cord, the blood pressure in the baby changes and the lungs begin to perfuse. Breathing becomes a primary focus. So, several factors help the baby start breathing. We have chemical factors like the catecholamine release that happens in the baby during labor. We have mechanical factors like the chest squeeze that happens as the baby's coming through the birth canal. We have thermal factors when that baby hits that cold air. And then we have sensory factors by drying and stimulating our baby to cry. Breathing is really going to be a very big focus in those first few minutes of life to help improve our baby's APGAR score. If a baby comes out and is limp and floppy and not really breathing well, drying, stimulating, and promoting respiration is going to help improve the heart rate, the muscle tone, the color, everything will get better with respiration. There's a few things that can affect respirations for a newborn. Inadequate surfactant. So we see this mostly with preterm babies, but we can also see inadequate surfactant for babies that are born to diabetic mothers as well. We can see it with inadequate fluid clearance. What that means is that the amniotic fluid is still in the lungs, and that is affecting gas exchange. We could see it with meconium aspiration, and meconium aspiration would be if the baby passed a bowel movement in utero and the baby breathed that in. Sometimes we also can see factors affecting respirations related to congenital defects and PPHN, which is persistent pulmonary hypertension in the newborn. So when we look at respiratory distress, there's a few signs that we are thinking about. Wheezing, effort, tachypnea, flaring, retractions, oxygenation, grunting, and seesaw breathing. And when we put these together, it makes wet frogs, and that's how we're going to look at this. W is for wheezing. Wheezing is that high-pitched whistling sound that you can hear, especially on expiration for our baby. And this might be heard if we have things that are obstructing the lower air passages and causing them to be more narrow. So things like pneumonia, meconium aspiration syndrome can cause this. Sometimes we can also hear it also with transient tachypnea of the newborn. We may only hear it with a stethoscope, and this is caused by an increased airway resistance. E is for effort. Effort is an increased work of breathing. We might see head bobbing respirations. And with this, the head moves back and forth depending on where we are with breathing. So we move forward with inspiration and relax back with expiration. We can also see a visible contraction of the muscles in the neck. So the sternocleidomastoid muscles might be contracting, and we can see retractions around the clavicles and around the windpipe with this. T is for tachypnea. Tachypnea is rapid breathing. So this is a respiratory rate that is greater than 60 breaths per minute for our newborn, and we're counting for 1 full minute because babies have irregular respiratory patterns. And so we need to count for the full minute to determine what the respiratory rate actually is. If it's greater than 60 breaths per minute, then that's too fast. This is a compensatory mechanism, and it's also going to be a non-specific finding overall. We can see tachypnea for a lot of reasons. We can see it with transient tachypnea of the newborn, which has the name tachypnea right in it. We can see it with meconium aspiration syndrome, pneumonia, and respiratory distress syndrome. Respiratory distress syndrome is going to have all these same signs of respiratory distress, but it is caused by that insufficient surfactant. That's what makes it respiratory distress syndrome. So all of these things can cause tachypnea. But we can also see tachypnea with infection, sepsis, hypoglycemia, cold stress, cardiovascular conditions. So this by itself is nonspecific of a finding. F is for flaring, which is nasal flaring. So this is the widening of the nostrils during breathing. And so this happens because it's increasing the airway size for the baby and it's decreasing the air resistance. So this is a sign of a baby that's trying to pull in more air. This is also a compensatory thing we see with transient tachypnea of the newborn, meconium aspiration syndrome, respiratory distress syndrome, and pneumonia. R is for retractions. And so this is going to be a use of the accessory muscles in the rib cage and under the sternum. For this, we see a dramatically visible sign of respiratory distress because that the skin is sucking in around the ribs and under the sternum, and this is happening when airway resistance is high. So all of this can be seen sucking in and the ribs under the sternum, also compensatory for the same conditions again, transient tachypnea of the newborn, meconium aspiration syndrome, respiratory distress syndrome, and pneumonia. And so anytime we see that tissue sucking in around the bones, around the rib cage, then we're concerned about respiratory distress. O is for oxygenation. In this case, the oxygen is low. And so this has impaired oxygenation, causes bluing of our baby, like the lips, the tongue, the mucous membranes. This is central cyanosis. Color is our best indicator of oxygenation. So if we have central cyanosis, this is a late sign of respiratory distress and a sign that we have significant hypoxemia. Now remember though that our babies could have acrocyanosis where the hands and feet have that bluish color, and that's normal in the first 24 to 48 hours of life. So we're worried about if we're seeing this bluish color on the face, on the trunk, in the mouth, places like that. G is for grunting. And grunting is short humming, almost musical sounds that are happening as the baby breathes out. This is heard without a stethoscope. You can usually hear it even across the room. The parents might think the baby's singing or humming because it makes a sound every time the baby breathes out. It's like, hmm, hmm, hmm. And this is, again, a compensatory mechanism for any of the conditions that we've already talked about. Transient tachypnea of the newborn, meconium aspiration syndrome, respiratory distress syndrome, or pneumonia. Seesaw breathing is our S. And with this has to do with the way that the abdomen is rising and falling with breathing. So babies are abdominal breathers. And so typically their chest and their bellies rise and fall together. If a baby is working hard to breathe, then you're going to see that we're seeing them alternate, where the stomach comes up and then goes down. And so the chest contracts when the abdomen expands. And so this is a sign of fatigue of the respiratory muscles, and the diaphragm is working hard to maintain that respiratory effort. And again, this is another compensatory response. So when we look at this all together, we have wheezing, which is the high-pitched whistling sound, typically on expiration. We have effort, which is that increased work of breathing. We have tachypnea, where we have respiratory rate that's greater than 60 breaths per minute. We have flaring, which is nasal flaring or the widening of the nostrils during breathing. We have retractions, where the skin is sucking in around the ribs and below the rib cage. We have oxygenation, thinking about central cyanosis or that impaired oxygenation. We have grunting, which is that musical sound that's produced on expiration. And then we have seesaw respirations, which is that exaggerated rise in the abdomen with respiration that's opposite of the chest. And that comes together to spell wet frogs. Thanks for watching. Be sure to subscribe, like, and share for new videos every week about everything OB. See you soon.